Hi, this is Sarah, and we're going to talk about Chapter 20, which is Somatic Symptom and Dissociative Disorders. You'll also hear these called as somatoform disorders. Here are your objectives for this chapter. Now, just an introduction, somatic symptom disorders are characterized by clients who have physical symptoms that suggest a medical disease, but they don't have a demonstrable organic pathology or a known pathophysiology mechanism to account for them. So for instance, somebody comes in with abdominal pain and we run all of our tests and nothing is showing up on the test, but they still have this excruciating abdominal pain. So once medical things are ruled out, and it can take a long time to rule out medical things, then we start thinking about, is this more of a somatic or have more of a psychological base to it. Somatization disorder is a long-term or chronic condition in which a person has physical symptoms that can involve more than one part of the body, but no physical or pathophysiological cause can be found. Now, the pain and other symptoms people feel with this disorder are very real, and they're not created or they're not faked, or they're not faked symptoms so that they can obtain drugs, or they're not malingering or anything like that. So the client is really feeling this pain, but it has a somatic origin rather than a physiological origin. Now, dissociative disorders are defined by a disruption in the usual integrated functions of consciousness, memory, or identity. Someone with a dissociative disorder escapes reality in ways that are involuntary and unhealthy. The symptoms of dissociative disorders can range from amnesia to having alternate identities, and anywhere on that range they can fall. Usually these develop as a reaction to a trauma, and they help keep the painful and very, very difficult memories at bay. Now, some historical aspects of these types of disorders. Historically, somatic symptom disorders have been identified as something called hysterical neurosis. Somatic symptoms disorders were thought to occur in response to repressed severe anxiety. Now, Freud, good old Freud, viewed dissociation as a type of repression, an active defense mechanism used to remove threatening or unacceptable mental contents from conscious awares. Statistically speaking, somatic symptom disorders are more common in women than in men. They're more common in rural areas, and they're more common in less educated people. Individuals with factitious disorders comprise about 0.8 to 1.0% of psychiatric consultation clients. So these types of disorders really don't occur very often. Dissociative disorders are statistically quite rare, but when they do occur, they tend to present very dramatic clinical pictures and severe disturbances in normal personality functioning. So when they do occur, we pay a lot of attention to them because they're very interesting. Dissociative identity disorder, or DID, is more common in women than in men, and brief periods of depersonalization symptoms appear to be common in young adulthood, particularly in times of severe stress. So, some of the types of somatic symptom disorders are going to include somatic symptom disorder, illness, anxiety disorder, conversion disorder, psychological factors affecting medical conditions, which is kind of this other category. Now, somatic symptom disorder is a syndrome of multiple somatic symptoms that cannot be explained medically and are associated with psychosocial distress and long-term seeking of assistance from healthcare professionals. The disorder is chronic, and anxiety, depression, and suicidal ideation are frequently manifested with this disorder. And the suicidal ideation is what makes it very, very dangerous for the person. Drug abuse and drug dependence are common complications of somatic symptom disorder. Personality characteristics include heightened emotionality, strong dependency needs, and a preoccupation with the symptoms and with themselves. Just if this helps you remember, soma is Greek for body, so that's where they get the name somatic. And it's a disease where they're preoccupied with what's going on with their body. Somatization is the expression of that physical stress through physical symptoms. And the diagnosis of a somatoform disorder requires the presence of a certain amount of symptoms accompanied by significant functional impairment. And it's the significant functional impairment that is the important part, because some people might be very, very obsessed with what they perceive to be physical symptoms, but if it doesn't really impinge upon their life in a way that they're unable to function, then they might not have a true somatic symptom disorder. Pain, GI symptoms or abdominal symptoms, sexual symptoms, pseudoneurological symptoms like some people will have complete numbness on one side. It'll actually resemble a stroke fairly much. These are all hallmarks of somatoform disorder. The course is chronic and relapsing, and patients who suffer from somatoform disorders spend an average of 7 days a month sick in bed. So if you think, people work 40 hours a week and they get, roughly 2 to 3 weeks of sick time and vacation time per year, that if they're spending 7 days a month in bed, they're going to blow through their sick time really, really quickly. And they're probably going to lose their job fairly quickly because you can't hold a job if you're going to be gone 1/4 of the time. Now, illness anxiety disorder. This is an unrealistic or inaccurate interpretation of physical symptoms or sensations, leading to preoccupation and fear of having a serious disease. Their behavioral response to even the slightest changes in feeling or sensation is unrealistic and exaggerated. So for these people, a headache isn't just a headache is a brain tumor. Anxiety and depression are very common, and obsessive compulsive traits frequently accompany the disorder. Conversion disorder, it's also known as functional neurological symptom disorder. This is where there's a loss of or a change in body function that can't be explained by any known medical disorder or pathophysiological mechanism. The most obvious and classic conversion symptoms are those that suggest neurological disease. In some instances of conversion disorder may be precipitated by intense psychological stress. Some of the common symptoms are paralysis, blindness, movement and gait disorders, numbness, paresthesias, loss of vision or hearing, or episodes resembling epilepsy. Comorbid conditions are often depression, anxiety, other somatoform disorders, and personality disorders. And then there's this kind of last category, the catch-all category of psychological factors affecting medical conditions. And these are what psychological factors can play a role in virtually any medical condition. And with this diagnosis, there's evidence of a general medical condition that has been precipitated by, or it's being perpetuated by, their psychological and behavioral circumstances. So basically, they might have a medical condition, and then these somatic symptom characteristics are either contributing to that medical illness, or it's making it worse, making the medical illness worse. Next, we're going to talk about factitious disorders. Factitious disorders are kind of interesting. This is the conscious, intentional feigning or faking of physical or psychological symptoms. Individuals pretend to be ill in order to receive emotional care and support that is commonly associated with the role of the patient. And this makes sense. I mean, people in their normal everyday lives, they take care of their children, they take care of their spouses, they're breadwinners, they're going out and working, they take care of the house, they take care of the animals, they're taking care of everybody else except for themselves. And then they get sick and they come into the hospital, and all of a sudden you have 24-hour staff basically attending to your every need. I mean, yes, you're ill, but for some people this is the only time that they are taken care of. And so they develop a factitious disorder where they basically fake symptoms so that they can be admitted, so that they can play the role of that patient. The disorder may also be identified as something called Munchausen syndrome. Now, if the patient or the person who has this factitious disorder makes somebody else sick in order to play the role of and usually it's a parent, to play the role of the sick person's parent, that's called Munchausen's disorder by proxy, or factitious disorder by proxy. And some people, and so basically what happens is, and it's usually parents, harm their children so that they can take them into the hospital, and and then the child has to be treated. And people sometimes are like, who would do that? That makes absolutely no sense. But think about it this way. If a child is very, very sick, the parent oftentimes gets a lot of positive support in regards to, I don't know how you do it, you know, you're so strong, you're such a strong mom or a strong dad. It's usually a mother, but it can be a dad also. You know, you are such a strong person, you know, here you are taking care of your very, very sick child. I don't know how you do it, you know, all that. And so that's where they get the positive part of it that they are trying to key into. So what they'll do is they'll basically harm their child in order to put them in the role of the patient. Now, with these factitious disorders, again, if it's the client that has a factitious disorder, they'll consciously pretend to be ill in order to get those emotional needs met. And what they'll do is they will either artificially, deliberately, or dramatically fabricate symptoms or inflict self-injury upon themselves. This might be they stab themselves in the abdomen, or they cut themselves on the arm and then they rub feces in it so that it becomes very, very infected. That type of thing. If they're diabetic, they might make themselves they might take too much insulin and make themselves go hypoglycemic. They might induce a seizure. One of them is they might either give themselves HIV or engage in activities that promote their acquiring HIV. And but in all of these situations, they're doing something to themselves so that they end up in a hospital in the patient role. Now, understandably, this results in very high health care costs and also disability to the individual. Now, there are three subtypes of this factitious disorder. There are predominantly physical symptoms, there are predominantly psychological symptoms, and there's combinations of physical and psychological symptoms. Okay, some examples of factitious disorders. Although most factitious disorders involve physical symptoms, some patients primarily report psychological symptoms, including hallucinations or depression, suicidal ideation, or intense bereavement over the loss of a loved one. There's also something called malingering. Malingering is the conscious process that somebody does when they fabricate an illness or exaggerate symptoms, usually pain, in order to become eligible for disability or commit insurance fraud, obtain prescription medications, usually prescription pain medications, or evade military service, or to receive a reduced prison sentence. So with malingering, by engaging in fabricating an illness, there is a direct consequence or a direct benefit to them that they're trying to obtain. That's with malingering. Munchausen syndrome is the most severe and chronic of the factitious disorders, and it's the most difficult to treat. And people who have Munchausen syndrome, they go from one care provider to another seeking very aggressive attention. For instance, if they have, if they're saying they have abdominal pain, they don't just want an ultrasound, they want to have exploratory surgery. And the key there is if you see someone who is doctor shopping, going from doctor to doctor to doctor, sometimes that's valid. Sometimes people are just trying to find a doctor that works for them. But sometimes they are doctor shopping and either trying to obtain multiple pain prescriptions, or it would be a symptom of this Munchausen syndrome. And people with Munchausen's, they've been known to stab themselves, inject themselves with toxins, anything to produce symptoms that necessitate drastic treatment and usually surgery. Now, that Munchausen by proxy, which I talked about earlier, this is where they do things to the children. They basically harm children in order to seek very, very aggressive and emergency treatment for the children. And usually the children that they're harming are under 6 years old, because the younger children aren't going to tell. They're not going to tell on their parents, especially if they're pre-verbal. They can't. They literally can't tell. And again, that aggressive treatment and that emergency treatment, the payoff for the person who has Munchausen by proxy is that they receive an enormous amount of sympathy for that caregiver role. Okay, predisposing factors associated with somatic symptoms. Genetic. There are possible hereditary factors associated with somatic symptom disorder, conversion disorder, and illness anxiety disorder. There might also be a biochemical factor there. They think decreased levels of serotonin and endorphins may play a role, predominantly when they're pain-based roles that they're seeking. Neuroanatomical, brain dysfunction or impairment of information in the information processing centers has been implicated as a factor in this factitious disorder. And then there's the psychodynamic theory. This suggests that illness anxiety disorders are an ego defense mechanism. Physical complaints are the expression of low self-esteem and feelings of worthlessness. Conversion disorder may represent emotions associated with a traumatic event, and these emotions are they're so overwhelming that the person just can't express them, and so they're converted into physical symptoms because the person can handle those physical symptoms while they can't handle those emotional symptoms. Family dynamics may play a role. In dysfunctional families, when a child becomes ill, there's a shift in the focus for instance, if you have two parents that are always fighting, and a child becomes ill, oftentimes they will band together in order to get through that child's illness. So the fighting stops in a way. But it'll only stop as long as that child or that or whatever thing that they're getting over is ill. Once the illness is resolved, all of those issues that the family was unable to resolve peacefully before, they're just going to start fighting again, and so it can really be just a circle that really has no end. Let's see. Learning theory. Somatic complaints are often reinforced when the sick person learns that he or she may avoid stressful obligations or be excused from unwanted duties. And these are called primary gains. So basically, when they're a patient in the hospital, they don't have to be at home paying bills, going to work, being a spouse, being a parent. All of those things that they need to do in their normal lives, they kind of get a break from when they're in the hospital. And so this is the gain that they're trying to obtain. They also become the prominent focus of attention because of the illness, or it serves as a means to relieve that conflict within the family, because the concern is shifted to that ill person and away from whatever the original issue is that they're fighting over. Past experience with serious or life-threatening physical illness, either personal or that of close family members, can also predispose an individual to an illness anxiety disorder.